Hello everyone. So now we're going to talk about two specific situations. Might be related in some aspects, some others will not. But one is talking about the endocrine, and the other part is the breast as an organ. We're going to start with the breast gland. Changes that can happen here is because the presence of tumors could be benign or malignant, some hormonal changes, some inflammatory changes within the organ itself. And the other thing that is very important to realize and remember is that there's a lot of lymphatic vessels. Now, 75% of all the lymphatic drainage of the breast will go to the axillary region. So if there's a cancer, carcinoma, or adenocarcinoma of that area, most likely metastasis will go first to the regional lymph nodes of the axillary area. Males with breast cancer are 100% less in terms of females presenting it. Gynecomastia by cancer or hormonal changes are the types of breast cancer that this will lead to. Benign tumors, the first and number one is called fibroadenoma. So fibroadenoma of breast is not a malignancy, it's a benign tumor, but it's a number one. It's typically young females, and these benign tumors, fibroadenomas, are hormonally sensitive cells. And remember that breast tissue as endometrium are going to have estrogen receptors for this matter. So breast cancer has estrogen receptors. Males or females will have this type, but in females, what I'm talking about is the number one benign tumor is called fibroadenoma. 2 to 5 centimeters of diameter of a mass, encapsulated, young females, and typically these are asymptomatic. Now, risk factors for cancer in women, breast cancer in women are 100 times more common than males. 35 years and up to 60, 65 years is the typical age. 20 and 30% of presentation in less than 50 years. So 35 to 50 years, 20, 30%. 50 to 65, the rest, 70 to 80%. Genetics has been known that there's a positive family history in about 20% of the cases. But interesting enough, 85% that have family history will not develop breast cancer. What are the hormonal changes that you might have? Higher estrogens, either two types, the natural or the synthetic. The synthetic is given because of menopause, of osteoporosis. So again, you have a patient, you have a client, has some therapy because of osteoporosis, receiving estrogens. Think about always, okay, what's going on have you doing your self-exploration, examination of your breast? Are you having some sort of problems within the endometrium? Probably you have to ask her, have you had it with a patient? That lady is over 50, 55, probably might have had a hysterectomy. Well, just make sure about that. And the presence of being nulliparous, so no pregnancy ever. Breast cancer is the most common malignancy in females and is second overall to lung. Carcinomas are the type of gland, so adeno is the type. Invasive ductal, which is 80%, is going to be one important factor for you to understand. Not the lobular type, where all the cells are confluent in one spot or localized, but the duct, where it is 80%, is going to be, it is invasive. And the other important thing is that 50% is going to be in the upper lateral quadrant. Not left side, not right side, but the upper lateral quadrant. And 20% retroareolar, just where the nipple is. And the places where they're going to be given metastasis, either lungs, bones, liver. The onset typically is late, because 80–90% will start feeling some lump at about 2.5 centimeters in diameter, and this is just a little bit over the board in terms of being able to be detected. Mammography and ultrasound will detect masses as small as 0.5 centimeter, and some lumps that are considered to be untouchable, and these are asymptomatic. So the general rule is any female over the age of 35, 40 should have, on a yearly basis, mammography. Biopsy is the only final way to make a diagnosis. The textbook mentions, and slides mention, the original slide just mentioned mammography, but I added the presence of ultrasound also. But if a question comes as which is the best method, a single one will be mammography. But in clinical ways, just one versus the two, there's like a 30–40% chances of getting more information with the ultrasound, and also going along with some risk factors, people that might have a little bit more risk chance. Over 40%, 40 years of age on a yearly basis, biopsy is the diagnosis. Concept that you have to know, the sentinel lymph node. This is something that is related with the presence of cancer and the chances of having those lymph nodes affected. The presence of a sentinel lymph node will give you the situation of already a metastatic disease. And this is important to do a lumpectomy, just remove the mass, or do a mastectomy, that this is most likely the situation in most of cases. The reason for this is to understand that staging 0 will have a 92% of 5-year survival rate, which is probably now increased when this statistics came out. But the important thing is that you already have that sentinel lymph node present. Chances of a distant metastasis is, so a 13% of 5-year survival rate is present. Like I said, most of the time the initial onset is by an undetected and asymptomatic phase, but the chances of doing a self-exploration is very important. If you be able to find some individual area and probably have a little bit of pain, if you master the skills of doing a self-exploration, could help you a lot. The diagnosis finally is going to be done with a mammography and or adding the, not just either one of them. Either you do the mammography for sure and or not add an ultrasound. Typically done by people who are specialized in this area. A biopsy will give you the diagnosis. The resection of a lump as lumpectomy or just removing that quadrant can be the minimal invasive procedures, if you're going to call it. But a mastectomy typically is going to be given and offered to these patients. 2 types of them, and this is important for you to understand. A radical mastectomy is not done as usual anymore, because this implies the removal of muscle and modified that will spare the pectoralis major, and this is something that is being done a little bit more often for reconstruction afterwards with a prosthetic. The situation is that it's important for you to know if a radical was done because you don't have action of that the pectoralis major. You have to understand why this happened. And also the removal of all those lymph nodes, the chances of a lymphatic obstruction and lymphedema to that specific right or left upper extremity is going to be, distal is going to be a big problem. So to rule out with pain and swelling locally, be careful. Sometimes no limitation, range of motion for shoulder, C-spine, some inflammatory infection or tumor, and most of these treatments will be conservative in ways. So the ruling out of having pain or swelling locally on the breast, think about some other conditions always. So observe what type of surgery was offered and correlate with those signs and symptoms. If there's some lymphatic changes, a swelling and edema, and it's ipsilateral to that, removal of the breast, well, there you go, you have the diagnosis because of the removal of all those lymph nodes. Limitation for passive and active range of motion for shoulder, or symptoms of frozen shoulder impingement. Those are 2 other important features, clinical features. So pectoral major muscle dysfunction, and the most important one that I fear for many of these ladies is the presence of the regional pain syndrome. The older term was a reflex sympathetic dystrophy, RSD, and this is something that the patient is typically producing or happens to develop because of not willing to move or exacerbating an amount of pain. So this is type of an exclusion diagnosis, not something that you open. Oh, you have an RSD. Typically you go as searching for other most common reasons for this, and finding nothing else abnormal. You find out because of the changes coming from vasodilation, some changes of temperature, local temperature within the hand or any given part, and swelling is going to be typical of this situation. The giving some treatment to relieve edema or the lymphatic drainage as massage techniques that you're going to learn, they're important to know and have well aware. So from the hormonal changes in breast, one of the situations as diagnosis is the fibrocystic changes. The old term was fibrocystic disease. Now it's just called fibrocystic changes. And like the name goes, if you break it, it's just the presence of fibrous tissue, scar tissue, and cysts. And this is typically a reactive and degenerative type of condition. As a general statistic, 50% of females will have some fibrocystic changes, and 10-15% are symptomatic, and the 20 to 50-year-old group as having symptoms. So 85-90% will be asymptomatic, just the presence of these cysts or the fibrous tissue. Gynecomastia means just an increased volume of breast, either by hyperplasia or hypertrophy. Probably any hormones or syndrome or cancer can cause this. Also, some changes at puberty, because those tissue cells react to those sexual hormones, and over menstrual cycles they can be tender or painful or with some symptoms. It's not necessarily called mastitis, because mastitis is not just an inflammatory change of breast, but typically goes with infection. Even though the name calls just for an inflammatory condition, most of them will have some sort of infection, either by staph or strep. And 10% of women going through mastitis are when they're breastfeeding. Lymph nodes typically close to this are swollen, and they are very painful and swollen. And there's limitation also in the range of motion for that shoulder or upper extremity. Typically, it's the onset is in the early stages with a small lump that some people may even mimic as cancer, because there are all this changes as acute inflammatory reaction. As you recall, the redness, the pain, the tumor, the presence of a temperature. And when this happens to develop into an abscess, then it needs that surgical drainage. But if it doesn't get treatment and surgically treated, then chronic mastitis will drain and remain a fistula. When this happens, the main reason to think about this is cancer. So a biopsy is needed to rule out that situation. So that ends up the part of breast. Think about, again, the main conditions that might happen. Either if you're a female, what have you experienced in the past if you have? If you haven't, then think about what you might see in clinic, and think about the cancer. Always think about the estrogen receptors that you have there. For the second part of it is going to be about the endocrine. 4 specific systems we're going to talk, or organs: pituitary, thyroid, parathyroid, and adrenal. Review again the anatomy and physiology of that pituitary, hypothalamic pituitary axis, and think about why there is some feedback as positive and negative feedback to balance those hormones in blood. Remember that the hypothalamus is the one receptor in your head or your brain that's going to detect the amount of either products, byproducts, or hormones that's circulating, and depending if there's a lot of it, then sends a negative feedback to the pituitary not to produce, and obviously not to secrete anymore. The pituitary will not send that signal and hormones to the specific organ, target organs, to produce more, either activate or stimulate more formation of a specific hormone or an enzyme or whatever has to be given or produced, and obviously not to secrete it anymore. When there's a little amount in the bloodstream goes into the hypothalamus, this center detects a smaller amount of that byproduct or hormone, sends a signal to the pituitary saying, we need more. So from that point, the pituitary sends that specific hormone to the target organ to produce whatever has to be produced. Talking about the thyroid, parathyroid, adrenal, testes, ovary, whatever. So the pituitary gland has two parts. The anterior part, which is also called adenohypophysis, and the posterior pituitary, or the posterior hypophysis, which is called the neurohypophysis. The anterior is going to hold 5 specific hormones, and they have those initials, or not an acronym, just the initials of GH as growth, but also it's called STH, somatotropin. Somatotropin hormone, so STH or GH is the same. Not to make a different, make a confusion with TSH. That's STH, thyroid, and somato. Somato means body. So growth hormone, the body grows. So growth hormone, prolactin, that's specifically for breast and for when moms are breastfeeding, unless there's a tumor, a prolactinoma. The ACTH is for the adrenal glands. FSH and LH are specific as gonadotropins for the uterus, the ovaries and uterus, and the thyrotropic hormone is specific for the thyroid gland. Review this chart and see again what are the target organs, and those target organs, what they do. Some react and some produce. So for example, growth hormone goes just directly to the growth plates for growth. But if it reaches the thyroid produces thyroid hormones, T3, T4. If they go to the adrenal gland, the cortical adrenal hormones, any corticosteroids that you can imagine. For the testes, testosterone and sperm are being produced by the action of FSH. But FSH also goes to ovaries, and when this happens, it's going to produce, stimulate the ova, produce estrogen, and also progesterone. LH goes into the testes also to activate in the same way for testosterone and sperm. When it reaches the breast, it just increases the production of milk. In terms of oxytocin, either goes again into lactation, and specifically a stimuli for that, and for uterine contraction in both times. When the baby's ready to be born, those contraction to start labor, and once the baby's born, to remove the placenta. And when it goes to kidneys, those oxytocin and ADH, the antidiuretic hormone, those are from the posterior hypophysis or neurohypophysis, and the ADH goes to the kidney, and this is for water reabsorption. So we already talked a little bit about the oxytocin and antidiuretic hormone, talking about the contraction of uterus pre and postpartum, and the resorption of water from the renal tubules and the kidney. But these are considered non-trophic hormones or non-endocrine organ to function. So these are only activating something within that specific organ, not producing anything. Two important things. Parathyroid and medullary adrenal. Remember that we talked about the cortical adrenal glands, ACTH. Well, the adrenal cortical has also the medular part. The medular part is not included, or not included, but it's not influenced by the pituitary hormones. These are not part of hypothalamus pituitary axis. The parathyroid is going to be directly stimulated by presence of calcium, and the reason why we're going to see it in a little while, and the medullary adrenal by stress and some of the sympathetic pathways. So we're going to talk about what happens in these specific 3 or 4 systems about having a hyper or hypofunction or the presence of tumor. Everything has to do with a regulation, balance, homeostasis. So function is regulated by positive and negative feedback. Anything that has to do with if you're talking about negative feedback, means that you have a lot of circulating substances in blood. If you're talking about a positive feedback, means that you have lowered whatever substance is going in, and there's a positive feedback to produce more substance or activate more of that target organ. Any increased activity of that target glands by the circulating hormones have a negative feedback to the hypothalamus pituitary, so there's no release of factors, like I said. But if you have a diminished circulating hormone, then that gives a positive stimuli from the hypothalamus to the pituitary to release factors for the hormone production. So the hypothalamic releases factors or hormone production by the adeno or anterior hypophysis are basically these 3. So production and secretion of TSH, ACTH, LH, and FSH. But still, remember that here also you're going to have the LH as for the breast, the PRL, I'm sorry, the PRL, and you're going to have also the growth hormone. So some concepts: lack of that trophic stimulation. So there's no trophic stimulation. Either there's an atrophy or incomplete development of that organ. And obviously there's going to be a decrease, or there's no hormone production at or by that target organ. Now there's a lack of response of that target organ and no feedback inhibition, you're going to have a hypersecretion of pituitary. So if there's no response, there's little to be in the bloodstream, so the sense is going to be that you have to produce more, so there's going to be a hypersecretion of the pituitary. Now if there's this hyper stimulation by those trophic hormones, that hyperfunction either is going to lead to an enlargement by hyperplasia of neoplasm. So just see this diagram, this drawing, where there's a hyposecretion by any of these reasons or a hypersecretion by tumor hyperplasia. There's going to be a positive input into the peripheral tissues, so there's going to be hyperfunction. Or there's a negative, so hypofunction is going to be related. So hyperfunction goes by any of these reasons, either incomplete development, so atrophy by infection or autoimmune diseases, and typically what's going to happen, there's a destruction of cells because of infection or autoimmune disease or presence of tumor, or also in this destruction of cells. That has to go eventually with some atrophy. The resection that can happen, typically the one that is mostly seen, is when a thyroid is removed, and the 4 parathyroid glands are also removed. So you get a hypoparathyroidism for this reason. So calcium and phosphorus level is going to be affected. And adenoma or carcinoma, differentiated, the only thing or the only difference with cancer is metastases. So any enlargement of endocrine glands might lead to some compression of the adjacent structures. If you're talking about the pituitary, you happen to have a cancer in the pituitary, your vision typically is going to be altered. So you're going to have a double vision, probably some quadrantanopsia, hemianopsia, something's going to happen with your vision as a compression of that optic nerve. The paraneoplastic endocrine symptoms is important to know because these are not distinguishable from the glandular activity itself from where they come from. So, for example, a small cell cancer lung will produce two specific situations or two specific hormones, the ACTH and the PTH. So the parathormone is going to increase calcium calcium release from the bone because of the activity of PTH, and the ACTH is going to bring more corticosteroid and symptoms that will be like a Cushing's syndrome, and this is when you have a tumor or you have a lot of steroidal substance in your body. So, but the paraneoplastic endocrine symptoms means that one cell, one tumor in a different stage acts or produces the type of hormones in other areas or actions in other organs. So the pituitary can have two types of functions, a hyper or hypofunction. Most of these are silent tumors, which means that they will not give any symptoms or signs locally unless they really grow a lot. Probably headaches could be one of them, but they produce a mass effect, like I told you. If they're just in the presence within the optic nerve, diplopia, double vision, or part of one eye or the other, quadrantanopsia, hemianopsia, those are terms of eyesight that's impaired. Hyperfunction can be, it's typically just in one of the 5 cell types, and so the whole organ or the whole gland will be enlarged. All of these masses are considered to be benign. The adenoma is the name of the cell type because again it's a gland, so it's a benign gland tumor. And it's just a one cell type. The other side, the most common one is lactotropic, the LTH or prolactinoma, which is accounts for about 30% of all pituitary tumors. The less common is the STH, as somatotropic, and the THS. STH remembers the growth hormone, and TSH, as the thyroid, is extremely rare. Malignant tumors are even rare. So prolactinoma could be the most common, that it's about 10 millimeters or less in diameter. Young females are the ones that are going to be suffering this. So girls about 13, 14 that have to a specific thing. Either they start having headaches, maybe having some sight problem, vision problems, not typically, but they are not going the next stage from being a girl into an adolescent, so they are amenorrheic, so they don't have their first period. They even might have some presence of milk coming from the breast, and that's even more classic of this prolactinoma. Obviously, infertility, to add it here at this age probably is not that common, but these girls go into be 19, 20, 21, even with a diagnosis. Well, so now they can be infertile. If they want to be pregnant, they can't. The hyperfunction, like I said, in macroadenomas, then can be the chance of having over a 10 millimeter. And now you're going to have another sort of situation with headaches because now they're compressing some other organs. For the STH or GH as growth hormone, you can see these two pictures. And I believe, if I recall what it says there, there's a difference of about 7 years. I don't think it's more than 10 years. But what happens is there's a benign tumor in this lady, obviously this one too, but see the features, how they grow, nose, ears, soft tissues, even some very fine characteristic of features in a female, they get more accentuated. So the term in children is called gigantism, so they grow to be giants. Acromegaly is termed for adults. So the excess of GH production is going to lead to two things: hyperglycemia and hypercalcemia. So these two measures, or these two assessments of blood sugar and calcium in blood, is going to be important or relevant to correlate if you have hyperglycemia in a child or an adult, and hypercalcemia in a child or adult, to probably facing a growth hormone adenoma. Hypopituitarism means that the whole gland is not working. So either it's a congenital or agenesia, or there's some tumors compressing this pineal gland, the hypophysis. Remember I mentioned Sheehan syndrome. So there's bleeding postpartum, and it's going to have a necrosis of the pituitary, and this is something that happens. 25% of these tumors, you have to understand, will not produce any hormonal changes or symptoms. But most likely what happens is that they erode the sella turcica and compresses the hypophysis and produce this hypopituitarism. So headaches, or because of pressure, or having intracranial hypertension, is going to be a main condition. Intracranial hypertension is very closely related with vomiting. Vomiting without any cause, and typically it's a projectile type of vomiting, and that's when you have cranial hypertension. And obviously that goes along with headaches. But you can have headache and not having intracranial hypertension. That's a concept of knowing which way which goes. And you can have either double vision or even go and progress all the way to blindness. With surgical resection, typically of these adenomas, the function will return to normal, but typically the size of the bone will remain larger. So there was some sort of erosion that's going to remain eroded. Hyperfunction of corticotropic adenomas is recognized as microadenomas, and it's typically Cushing's disease what's going to happen. Hypofunction is going to decrease limitation of one cell type, and either can be of the ACTH, hypogonadism, or diabetes insipidus, but not having the ADH. So you have a lot of urine, but the type of not having the osmolality and all the changes that you expect on a normal urine is because you don't have an antidiuretic, so you're just voiding your bladder constantly. The thyroid, you're going to have a hypo also. When you have a mass in this area, it's called goiter. Can be neoplasm or cannot be a tumor. In terms of hyperthyroidism, T3 and T4 are the active hormones, and probably not necessarily mention it as active. They have to be activated in some ways. But the excess production will also lead to a hypermetabolic state. And you have heard in many cases when you want to lose weight, and one of the things that you want to make sure is that you're not receiving thyroid hormones to increase your metabolic state, and because of that, increase your weight loss, because there are going to be some other problems because of that reason. So some of the causes for have a high T3, T4, either autoimmune, which is the most common of it, is called Graves' disease. Graves' disease accounts for about 85%. What happens is that there's some antibodies to the TSH receptor in one of its particular cells, which are called the follicular cells. Females are by far much more prone to have this hyperthyroidism than males. And some of the things, if you look into the book, there's a picture, I believe, or Google it, they have this exophthalmos, which means the eyes budging out, looks like that. People tend to sweat a lot. They lose weight, like I said, and that's even part of some treatments to lose weight. And they do have increased appetite. But the other thing important is because the thyroid hormone is going to be working with your heart. You're going to have some agitation, some tachycardia, some feelings of heart palpitation, muscular tremor. You're not going to be able to rest. You feel nervous, or even you can lead to some bouts of diarrhea. The idiopathic type, which is called the idiopathic nodular hyperplasia, the toxic goiter is the common reference to this, can be cause tumors and adenomas as being the first cause. Some diet pills, like I mentioned, or some uncontrolled intake of thyroid will cause this. So go again with this flow chart from the hypothesis. What causes normal stimulation by the TSH into the thyroid, and you can have either some receptors blocking it, so you're going to have Graves' disease again. Follicular cells, 85% is the chances for this, or a nodular goiter will go and stimulate again the hypophysis to increase TSH, or you're going to have an adenoma that is going to also be acting over the hypophysis, or you have some thyroid pills taken and you're going to be also giving some sort of action for that matter and having some inhibition of the formation of TSH under some of these circumstances. So inhibition, blue with blue goes like that. So think about when reading this in your course notes. So hypo is the opposite effect, and this is something that has to do with a low T3, T4. The most common cause also is going to be Hashimoto's thyroiditis, and the Hashimoto's thyroiditis is another way of immune condition. Again, females are more common than men, but here 60 years of age and older. And could be congenital, and this is something that as a newborn screen exam is done in every single baby since, I don't know, 40 years, 45 years. It's a law that you do a thyroid test, because this is something that can be easily taken back to normal by giving some thyroid supplement for this. Or you had a thyroidectomy, sort of a removal of thyroid is going to give you hypothyroidism, or you have this deficiency of iodine. The enlargement of the gland, remember, is called goiter. So this is something that you see some pictures in National Geographic of some countries where the people don't have iodine in their salt or in their diet. They tend to have an increased volume of the thyroid for that reason. In children, like I said, newborns, you can have hypothyroidism, and this is important because if they happen to have hypothyroidism, one of the things they're going to have is what is called a thyroid dwarf. They do not grow, they don't develop normally, and if they have mental retardation, it's called cretinism. So the cretinism or the thyroid dwarf are two conditions, one with mental retardation, the other just the developmental. In children, in adults it's called myxedema. The myxedema, typically contrary or opposite to the hyperthyroidism in adults, these people, myxedema, are sleepy, tired, they don't have a lot of endurance, they're mentally slow, radiopsychia, they have bradycardia, so their heart's not beating at a normal pace. Muscle typically ache, they're weak and stiff. By diagnosis, you're going to be able to find this on T3, T4, TSH levels. So with hypothyroidism, obviously you have very low T3, T4, probably a high TSH. With a hyperthyroidism, you're going to have high T3, T4 with low TSH. Just a way of looking at two diagrams from the thyroid gland, where it's located in the anterior part of the neck, goiter, what it's called, and a thyroid with a normal lobe. The hypofunction side on the left, hyperfunction on the right. Hyperfunction, think about why those hormones as T3, T4 are acting more, and that's what you'll find as a diagnosis. And obviously you have high T3, T4, there'll be a negative feedback, so TSH has to be low. With a hypofunction, remember that you're going to have a low T3, T4, so hypothalamus is going to say, hey guys, we have to work more, so there's going to be a positive feedback, and you're going to produce more TSH for this matter. So read about all the changes that you have as cold intolerance, or the warm skin, sweaty palms, and the hyper, diarrhea versus constipation, weight loss versus you're going to be overweight in one way, the puffiness that you have versus the exophthalmos that you have with a hyperfunction, loss of hair and thin hair is going to be different. Besides, the hair is brittle, coarse on the hypo. So those are main things. Edema of the extremities versus pertibial edema are also present. Hyperreflexia that you have the hyper versus muscle weakness that you have in the hypo. So nodular goiter, like I said, it just means that there's an enlarged thyroid and has a form of nodules there, mass present of any cause. Typically, this is a normal thyroidal metabolic action or function. And what happens is that it may compress several structures, more specifically the recurrent laryngeal nerve, and this will bring hoarseness or to the larynx directly. And thyroid neoplasms, the difference is that females are more than males in presence. Benign, most common are the adenomas. Benign are going to be much more common also than malignant. The follicular adenoma, remember the follicular cells are the ones that are going to be implied here in the thyroid, is the most common benign tumor. Important to realize is that the only way to make a diagnosis as confirmation, it has to do through a biopsy. Most of them will not need treatment, but because this adenoma with goiter presence, the removal for cosmetic purposes might be requested or indicated. So carcinoma, one of the things that I want to share with you as females more than males is, and I think I did this in the past when we talked about neoplasms, carcinoma of the thyroid has increased many folds recently because of radiation. Ladies going into the OR without protection, or therapists that are in hospital or very close to a radiology office that is taking radiographs constantly. Make sure that your walls are well shielded. If you don't know about that, probably the easiest way is to get a thyroid shield. It's just like a scarf. It's not that expensive, but can hold a lot of cases for you to not to worry about the presence of carcinoma. The papillary type is the most common one, 80% of all of them. And the thing is that these are hormonally inactive. It's a slow-growing tumor. Early in life, as 30, 50 years of age, the good thing is probably 80% or more are survive after 10 years. The others are the follicular, which is just 15%, the medular, and the anaplastic. I'm not going to go through these, but think about when reading about them, what are the survival rate, and probably just take care of the papillary one as being the most common for the thyroid. The parathyroid glands are four that are over the thyroid in each side, and these have a specific stimulus, or gets a stimulus through the kidneys. It's known that with one parathyroid gland is enough to maintain calcium and phosphate homeostasis. Same thing, can be hyperparathyroidism, hypoparathyroidism. So when you look at something like this in the center, is a normal one. You can have a primary hyperplasia or a secondary hyperplasia, and again, this is stimulated by the kidney disease. When you have a hyperplasia or hyperaction, we're going to talk a little bit about this, is the metabolism of calcium being increased. And same thing here with an adenoma, which is a benign tumor, or carcinoma. It has to be an adenocarcinoma of the parathyroid gland. is related with one or some other glands being affected. And hyperparathyroidism, think about hyper, there's more of calcium being reabsorbed in a way. So high PTH is being caused primarily by neoplasm or hyperplasia. 80% will be adenoma, which is benign, or could be in multiple S2-3 glands. Secondaries by chronic renal failure or disease. And this is something that it makes no real difference, as it's not necessarily distinguishable from a primary hyperplasia. But the hyperfunction is going to be a compensatory mechanism that's triggered by hypocalcemia. So that's why it's called secondary to chronic renal disease. Rare and hereditary. This is the flow chart for PTH, either from an adenoma, hyperplasia, goes into the bone, into the kidney. Those are the two target organs for PTH. In bone, there's a resorption of calcium. So what PTH does is go into the osteoclasts. Osteoclasts are the specialized cells of the bone that resorb calcium from the bone and release it into the bloodstream to increase levels of calcium, and where calcium has to be working. Think about the heart, the neuromuscular junction. Those are places where the cisterna and the muscle action, remember the cisternas that are there, and how the myosin and actin and myosin fibers or filaments have to work through the cisterns once calcium is released and reabsorbed. But once goes into the bone and acts over the osteoclast, bone, calcium and phosphorus release into the blood, and this will lead to hypercalcemia, hypophosphatemia. Obviously, there's a control also to reabsorb back to the bone these two specific minerals. In the kidney, an increased calcium resorption is going to be causing this hypercalcemia, and same with the phosphate excretion. So for calcium goes reabsorption, for phosphate it throws it away. And once it reaches the PTH to the kidney, this is going to help to activate vitamin D inside the intestinal tract. So same thing, increased calcium uptake by intestinal mucosa leads to the hypercalcemia. So excess PTH in blood is going to act over kidneys and blood and bones. In bones, it stimulates osteoclasts, resorption of bone, and release of calcium into circulation, and goes, like I said, to all the muscle action, heart included, and neuromuscular junctions. PTH in kidneys reabsorbs calcium from tubules, promotes activation vitamin D3 in kidneys, so this will ease the uptake of calcium in the gut. But in the phosphate, for phosphate, it throws it away. It's an excretion of phosphate. And so, again, understand that in serum, PTH being elevated is observed. The thing here with hyperparathyroidism and signs and symptoms is increased by that PTH activity. Bones will be decalcified. So remember, PTH goes, acts into osteoclast, removes calcium. So bones are decalcified. Easy fractures might happen. When this is a situation, as pathology goes, it's called osteomalacia. Hypercalcemia was going to cause kidney stones, lethargy, muscle weakness, heart conduction defects. Like I said, calcium has to do with muscle action. So if you have hypercalcemia, muscle weakness, and arrhythmias is going to be two big things. And being lethargic, not being awake most of the time is going to be a problem. And the hypothyroidism is the opposite, obviously. And here, the most common reason for this is the surgical resection of the thyroid and removing those parathyroid glands, typically or usually will be by mistake. Other causes will be quite rare. In hypothyroidism, is the opposite, because PTH, as not being there, is not going to be acting over the osteoclast, so there's hypocalcemia. Now here with hypocalcemia, low calcium increases neuromuscular excitability. So muscle contraction goes into spasticity. So you're going to have a hypocalcemic tetany. And one of the reasons to check hypoparathyroidism is the Chevostek sign that you hit over the masseter muscle, and you have contractions. And that's a hypocalcemic tetany. Beside your hand, carpometacarpal or pedal contraction, you're not going to be able to move it normally. So that's the spasticity. And also goes with arrhythmias, but here, the hypocalcemia will go because bad conduction, finally a cardiac arrest. And again, this is quite simple to make it work with supplemental synthetic PTH and obviously calcium. For the adrenal glands, 3 zones that you'll have for the cortical area as glomerulosa, fasciculata, and reticularis. Fasciculata, or the middle zone, is going to be the one important because of cortisol. Nevertheless, aldosterone is also important. Remember, for high blood pressure or blood pressure, not high, just blood pressure control, aldosterone is an important thing because it absorbs water and salt. Cortisol is the production of cortisone or the adrenocortical hormones here, and androgens are typically produced here at the reticularis, which is the most deeper zone in the adrenal cortex, and this will cause adrenogenital syndrome. So Cushing's syndrome is the increased amount or level of cortisol, most likely from adrenal gland, but you can get Cushing's syndrome because you're getting steroidal medications. When do you get steroidal medications? Because you have allergies, you have asthma, you have cancer, and what you typically do to give a steroidal medication is to try to level the balance in the cell membrane in a way. But most of these tumors, 70%, occur as secondary to an adenoma at the pituitary with high ACTH secretion hyperplasia tumors, and other reasons, like I said, the paraneoplastic tumors coming from small cell lung cancer is about 10% only. So this is a Cushing syndrome, full moon phase. You don't see the back, but there's a buffalo hump, what it's called, thinning of the skin. If you ever give an injection of a steroidal medication for Decker veins disease or for any condition, make sure that it's way deep down. If you leave it close to the skin, you're going to cause skin atrophy, and skin atrophy is going to leave a blanch or a blanched area on the skin, and it's not a pleasant sight, and that's irreversible. So you also have hypertension, what it's called in the skin, all this striated type of features. Typically the patient is weak, fatigued. Another thing is that they increase weight by far, and they increase appetite tremendously, and they get all this acne type of features. So acne is not here, but you should know it happens. The overweight or the chances of increasing appetite is also present. So a tumor, as you can see here, and the adrenal gland, this is an adenoma of that specific area. So the most common cause of Cushing syndrome is an exogenous administration of a steroidal medication, either by injections or orally taken. Autoimmune diseases, rheumatoid arthritis, lupus, asthma, nephrotic syndrome, skin conditions, anything that you need a steroidal medication can do it. Now, you do it once or take it once, or apply it once, typically that's not a problem. This is chronic. And the other thing is to know is with steroidal medication, when you have been taking it for quite some time, for example, you had a poison ivy dermatitis, and you have this type 4 hypersensitivity reaction because of the poison ivy, you're given cortisone for this orally. So you're going to be taking it, and probably you're taking, I don't know, 50 milligrams, 75 milligrams, 100 milligrams, until you control it. It can be in 5, 6, 7 days. You have to taper it. You have to bring it down gradually over 2-3 day periods to make sure that you won't fall into a withdrawal syndrome. Aldosterone, like I said, is a very important hormone, also related with the production of this by activation of the renin-angiotensin system. Remember from kidneys and renal function about the renin and how it activates or is secreted by the specific cells in the kidney, and to activate angiotensin, and those two will go and stimulate aldosterone to be able to retention of sodium and water. When something like this happens, hypertension is going to be the clinical feature, and this is called hypernatremic hypokalemic hypertension. So you lose potassium, you retain water and sodium. This is typically cured only by surgery. Now there's that primary hyperaldosteronism, but then you can have a secondary, and this is typically by kidney function. And again, this renin-angiotensin system physiologically will control the aldosterone. So this is called hyperreninemia. Serum levels of renin and aldosterone is to rule out any the difference between a renal and an adrenal type of situation. The adrenogenital syndrome is from the production of androgens of those specific layer of the most deep part of the cortex. And well, you can have an adrenal hypofunction by any of these reasons. And the most important one as adrenal hypofunction is Addison's disease or adrenal insufficiency. Somebody that had Addison's disease, and it was not really published a lot, it was J.F. Kennedy. J.F. Kennedy had Addison's disease. And in those days of 1960s, or probably late 50s, it wasn't that easy to know a lot of this, because of the reason why you could have adrenal insufficiency. So even though President, he never really showed any sort of fatigue or weight loss or nausea, or that I know susceptibility of infection. What he really did have also was low back pain, probably from some listhesis or some spondylolysis that was not treated in a moment after his action in World War II in the South Pacific. The other thing is that the diagnosis with ACTH test will bring no effect by no secretion of excess corticosteroids. So here you have Addison's disease and Cushing's syndrome as two of the most relevant: hyperfunction of the adrenal gland and Addison's with hypofunction of the adrenal gland. See if you can recall some of those changes for your own knowledge. The adrenal medulla, these are the two last slides. Two things to think about. One, the kind of tumors that might happen is the neuroblastoma and pheochromocytoma. And this adrenal commonplace is going to be the neuroblastoma. They have an embryologically origin, and the thing is that these type of cells, as chromaffin cells, they have epinephrine and norepinephrine. This is the other important thing about this. This might happen in either neonates and young children as the neuroblastoma. And they might be malignant tumors and metastasize by the time of diagnosis, but typically they are easily or early recognized, and combined treatment can give over 90% of cure. So the pheochromocytoma is the most common tumor of adrenal medulla, not adrenal gland, adrenal medulla in adults. And the main clinical feature will be hypertension. Why? Because these are solitary benign nodules that will actively be secreting epinephrine and norepinephrine. And these are in combination what is called catecholamines. And what this is, the presence of higher levels of epinephrine or norepinephrine, is the clinical feature of having hypertension. And this is what is called a malignant hypertension in most of the cases. The only way of treatment really is surgically, with excellent prognosis, as 90% are benign, and because of that benign nature, they're well encapsulated. So look at this, looking at from the adrenal area, the medulla, producing norepinephrine and epinephrine. How do they change or do byproducts in blood and urine? And in the urine, the way that we're going to be able to find is by the presence of VMA. What's the clinical impact of this? If you have a patient with hypertension, not controllable, even with typical medications coming from diuretics or some other type of measures, exercise, whatever, and it's quite young in age, even though it's not mentioned here what age you might have pheochromocytoma. Think about it, if hypertension is long-standing, sometimes increases a lot, and just mention it. Well, I heard about this. Could you think about doing this exam in urine, VMA, vanillyl mandelic acid, VMA, and if it's positive or present, then you have the diagnosis as a malignant hypertension. So we'll conclude here the part of endocrine. Review each of those titles carefully, so you'll be well prepared for the exam. Thank you.